we've got here is failure to communicate.
That is a classic. Has anybody seen that movie?
Yeah.
And that's just a classic movie, Cool Hand Luke. That line right there, what we have here, failure to communicate, you could pretty much go across any spectrum of a relationship. Be it between you and a parent, you and a child, you and a spouse, you and a patient, you and a friend, you and an administration, you and a patient, but also within you as well. Right? What do we do as chiropractors? What do we do as chiropractors? What do we do? So what does that have to do with failure to communicate? Isn't everything we do about communication? Isn't communication the basic line for life? By the way, this is not an Andy Roberts ego trip. This shirt was given to me as a gift from a good friend. I'm taking the Diploma in Philosophy class in Chicago, which I recommend for everyone. In fact, we do have a first year coming up in Chicago, the ACP, Academy of Chiropractic Philosophers. Long story, but I'll actually be in that class too. I know they wanted to bring that class here. I recommend it for everyone. I don't know if it's going to come here, but if you're able to, I would suggest that you make it to Chicago. We have dates in August, December, and February. Only 4 weekends. The third weekend is in October at Spartanburg at Sherman during IRAPS. 4, then you get your first year certificate. And it gives you the basic fundamentals. I know here at school we like to think that we're getting a good philosophical foundation, but that tends not to be the case from some of the things that I've seen posted and read and hear about. Nothing bad, nothing good, just is what it is. So if you want to get a better understanding of our chiropractic philosophy, that would be a really good way if you could juggle that into your studies. Value to get. So I'm here. I know you get a mix of speakers that either will stand up here and just talk at you, give you what their perspective is, or give you what their agenda is, or they just sit here and say, I'm just going to let Nate flow, whatever that means. But I'd like to kind of do a combination of the two. I want it to be interactive, for me to sit here and talk to you and talk at you. Honestly, it doesn't do anything for me, and I don't think it does anything for you. So I want the program to be interactive. If there's any questions or problems or concerns or interests that you have or have had up to this point, free to ask. And it doesn't have to be upper cervical. I almost hate when I'm introduced as an upper cervical chiropractor because I hate labels. You're either a chiropractor or not. It's like the whole straight mixer thing. What does that even mean? Because it is chiropractic or it's not chiropractic. Does that make sense? So either you are a chiropractor or you're not a chiropractor. There's no difference between the upper cervical chiropractor and the full spine chiropractor, right? They all have the same starting point. They should have all the same ending point. It's just that they take a different vehicle to get there, a different road. Does that make sense? One not better than the other. In fact, Lyle Sherman. Does everybody know who Lyle Sherman is? Everybody knows who Lyle Sherman is? So Lyle Sherman. Let me see if I have a picture. Cool guy. Lyle Sherman is that guy. So Lyle Sherman B.J. Palmer started the Palmer School of Chiropractic after he took it over from his father, developed the chiropractic philosophy, and then had a genesis of thought in the evolution of what the art was. Okay, so what are the three components of chiropractic?
Philosophy, science, and science.
Philosophy, science, and art. And you know they're fond of using the classic three-legged stool. Everybody's heard that one for chiropractic. 3 legs, philosophy, science, and art, and then the top makes a steady stool. But I have a problem with that. I don't think that's a really good analogy. Because the problem with that is that on a stool, you can unscrew one leg and screw in another one in its place, and I still have a good stool, don't I? Does that make sense? I can unscrew the philosophical leg and put in a therapeutic model, and I still have a stool that stands, yes? I can still mix it in with science and mix it in with art and call it chiropractic, can I? Therefore, I don't think that's a really good model. I think a better model is a tree, really. I think the tree, the actual trunk and the roots are the philosophy. That's the foundation. That's what makes a tree a tree. From the trunk comes a shoot. That's the science. Now, what's the science do? Does the science study things like, does chiropractic help hemorrhoids? Does chiropractic help MS? Is that what? No. The science of chiropractic should answer the questions that the philosophy asks. Does that make sense? So you have the philosophy, out from there is the science, and then as a melded branch from the philosophy and the science, now you have the art. Because the art is the application of what the philosophy says we do that's been answered by the science. How does that sound? Is that a little bit better model? That's why the philosophy never changes. Unless there was some epiphany where we were wrong. Like, oh man, you know what? The world actually isn't flat. It's round. But we haven't had that experience with the philosophy that we've developed from our first inductive major premise, which states what?
The universal intelligence he constantly get into his properties and actions, thus maintaining.
Right. Now, why is that an inductive? Does everybody know the difference between inductive and deductive? Okay. Okay. And the other way is from big to small and small to large, right? Here's the thing. Can you ever prove that statement empirically? No, because how could you ever know in all matter? You don't even know where all matter is. But that's our a priori statement. That's our foundation. If that's true, if you deduce things from it, everything that you deduce has to be true. Does that make sense? So that's where our principles come in. Your principles, that's like your rock. When you talk about anchored to a rock, anchored and chained to a rock, that's your rock. Because that's our proof, and all the way through gives us our reason to be. Everything that we do in chiropractic should be run through the filter of the principles. If you ever have a question, somebody stands up here, I stand up here, and I start telling you, hey, yeah, you know, I've invented a new technique. I take a potato, but it has to be an Idaho potato, and you put it on their back, and you spin it, whichever side that the one with the eye on it, on the potato has pointing, that's the side of laterality. But we laugh, but there are crazy techniques out there that are called techniques. It seems like all you need to do is have a DC after your license, and you could start naming a technique or calling a chiropractic technique a technique. You have your principles, we have our principles, that should guide us. That should be our filter. Right? Who has kids here? Okay, not so many. But those who don't, imagine if you did. And I was the creepy old man at the park saying, kids, look at these pictures. Right? Dad, is that cool with you? Not so much. Right? Dad's going to say, let me see those pictures first. Oh, and they might be like fun little clowns and fun pieces of art. Or they might be some nasty stuff, right? And if it was nasty stuff, I'd kick my ass and move along. We have Dad now in chiropractic. Not me. You have Stevenson. He put it in there for us. Those 33 principles. That's our Dad. That should be the filter through which we put our chiropractic experience through. regardless of who it is, me, an instructor, or anything else that you read on Facebook, in any technique program, anywhere. If they say they're coming from chiropractic, you say, that's cool, let me just put it through the filter. And if it doesn't shake through the filter, you know what you can do with it? Exactly. If it shakes through the filter, cool, move on. We're good. So we have the foundation, which is our chiropractic philosophy. We have science that is answering questions for us that we got from the philosophy. And that's kind of steady. What changes is the application of that, which is the art. That's why B.J. Palmer had that long journey over the years of changing. Who knows the history of technique? Who here owns Stevenson's, first of all? Everybody owns Stevenson's? Awesome. Almost everybody. If you don't have it, get it. You can get it at the bookstore?
Yes.
If not, it's 20 bucks here. 20 bucks in hardcover. I so love hardcover, that's better. I just saw it on Amazon, actually, being sold for $15 Kindle. So, oh no, that was only 19. I'm so sorry. Get that too. See if it's on Kindle. Don't use the one that's free, because it's pirated, and that's just not right for somebody's work. Buy the one here in the bookstore, see if you can buy it through Amazon, or give Robson a call and get his disc at least $200 for all of the green books on there. So well worth the investment. Where was I going?
Evolution of technique.
Evolution of technique. Okay. So the evolution of technique. Where did technique start? Who gave the first adjustment? BD. What was it?
C2.
C2. And why would you say C2? DD said it was T4. This is the upper cervical club, so it must be C2. Everybody knows there is the version of D.D. Palmer's that he adjusted T4, yes? Okay. My question to you is, does it matter? Does it really matter which one he adjusted? For chiropractic's sake, does it matter? It doesn't mean anything. And we'll never know the truth, right? Because both of them are dead. So we either take D.D.'s account, or we take B.J.'s modified version of the account, who said he was there, but if you just do the math, B.J. was born in what year? 1881. First chiropractic adjustment was given in.
1885.
Makes him how old? 14, 13. So,
13, you said?
14, right? 14? What is it? 1881 to 1895. Totally confident, had he stayed in his head by the time that he was 50 when he wrote the other version, right? And had he not gone through the evolution of technique, which we're going to talk about, right? So that first adjustment was given in either one. The majority of the adjustments in this first year, where was it given? Where? Not yet everywhere. Actually, really interesting. Just in the neck. Just in the neck. Then, once they realized that they didn't have the cure, Dee realized they didn't have the cure for deafness, but people started saying, wow, you know what? My breathing's better, and my heart's better, and my stomach's better. Now he began to connect other things with it. So he began to reason, if I could pop a bone here and it affected this, maybe if I pop the bone here, it'll affect this. And if I pop the bone here, it'll affect this. So that's where we came up with everyone. We're not kidding here, they actually mobilized every single segment. What kind of bench was it at first? It was a bench, like a park bench. It was a white, solid wood park bench. And what, do you know what the position of Harley Lillard was when he gave that adjustment, that thrust? Face down, on a piece of wood. So do you know what the biggest problem with patients were back then? Bloody noses. They were running. You know what Dee said? Who cares? Curing you. So he went from this to hit every one of them. right? And it was literally all the segments. What was the first major breakthrough technique-wise? Or the first major evolution in technique that happened about in the 1910s to the 20s? What is it?
Nerve tracing?
Nerve tracing, which goes hand in hand in what technique? The Merrick system. Excellent. What is the Merrick system? Right? So they had things like what? Like KP, which was the kidney place, and the HP, which was the heart place, and the TP, which was the toe place, or the tissue place, I don't know. So they had all of these things in the whole map. They would nerve trace, and they got more specific. So instead of adjusting all of them, they only thrusted on about 6 or 7 of them. Okay? They did something with the nerve traces called hot boxes. What was that? Use their hands. So they would run their hands into the back of their hands, up the back of the spine, and the front of their hands, and see which side was relatively hot compared to the other. Why? What was the thought? This is important to know.
Pulling out the plates and pressure on the neck.
Okay. So inflammation where?
That's it, or the
At the IVF. Does that make sense to you? I could feel the heat of the nerve at the skin? No, that actually was his thought. His thought was that if I had a nerve, which he likened to an electrical conductor, if I constricted it, much like an electrical conductor, if I put pressure on it, it would cause friction from resistance. That friction would cause heat, just like in an electrical wire, and that's what I'm measuring. Now here's the crazy thing. This is what I love about chiropractic. We can have the argument whether he got lucky or not. I like to think not. He was wrong, right? We can safely say he was wrong with that. We're not feeling the heat of friction. But the measurement of heat was right, which is so cool. And we'll get into that in a minute. So what was the next generation? What was the next evolution from Merrick system? Majors and minors. How many segments were that? That was about 3, sometimes 1. So now we were getting even a little bit better. Nerve tracing was starting to go out. In walks Dr. Evans. He came up with the neurokilometer. You know, Dr. Evans wasn't actually a chiropractor at the time. He was an engineer, and he was working in the Palmer School of Chiropractic. He would see the docs doing this stuff, and he said, no, I think I can do something better. So he took this bimetal technology. When you put 2 pieces of metal, different metals together, if you put a heat gradient over it, and you compare one side to the other, the deformation of the metal, because of the 2 different types, can actually feed through a galvanometer, and you can get a reading of relative heat. So now instead of using my hands, which are entirely, yeah, that's kind of like taking a blood pressure, right? Depends on how good my hearing is, whether you have high blood pressure or low blood pressure. Yeah? So the same thing here is, I mean, let's just talk chiropractically for a minute. What if I, a chiropractor, have a vertebral subluxation? Am I perceiving my world properly? Not so much. So now I'm making a judgment on something from my perception which is probably off. So Dr. Evan walks in, he designs the neurokilometer, and now we start BJ's run on constants and variables. His thought of making everything scientific. He always had that thought, but now he began to have the tools to do it. By the way, in that story, Dr. Evans actually became a chiropractor, went to school, was a great chiropractor, stayed with the Palmer School for a long time. Okay, what was the next generation after majors and minors? The next evolution? Hole-in-one. What's a hole-in-one? Toggle recoil. So now you're talking about the adjusted thrust of a technique, and you talked about a system. Does everybody know the difference between a system and a technique? And a procedure? And an analysis? Do you talk about that much here? Okay. The system is the overall encompassing health system. Upper cervical is a system. It's not a technique. I don't do upper cervical technique. You do an upper cervical, at least in my office, it's an upper cervical system. It is all inclusive. It's all I do. From soup to nuts, bolts to nuts, something like that. Everything. Okay? Full spine is a system. That's the umbrella. It contains everything. In fact, you can even have other systems like a therapeutic system or a non-therapeutic system. Okay? A technique is so if the system is the, remember I used that analogy of the highway getting to the same place? If the system is the highway, the technique is the vehicle which I drive on that highway. So in the upper cervical system, I can do Grostic, and I can do Nuka, and I can do AO, and the other AO, and I can do the art of the specific, and I can do Gale, and I can do, the list goes on, right? Same thing here. If I'm in the full spine system, I can do Thompson, and I can do Gonstead, and I can... Now, here's the interesting thing. In the upper cervical system, can I do diversified? Absolutely can. I absolutely can. I can do the technique of a diversified and apply it only in an upper cervical system. Do you see that? Now you begin to see the difference? Can I do the art of the specific, or can I do Nuka in a full spine practice? Of course I can. I can do that, and I could also do activator or Gonstead or whatever. So let's get out of our head that and understand that there's differences in a system and techniques. In fact, you can do the upper cervical system and have a number of techniques, upper cervical, that you do. All right? You can use Nuka, you can use side posture, drop headpiece. A procedure is more like diversified as a procedure. There's really no analysis in diversified. Diversified is actually just a technique of moving a bone. And then you can look at like other techniques, quote unquote, that are just analyses, multiple analyses, whatever. That you have an analysis, but then you need to use a technique to address that analysis, or the findings from that analysis. Okay? The system incorporates it all. In my world, I am in the upper cervical system, using the art of the specific as my technique within that upper cervical paradigm. Okay? The biggest big misunderstanding, toggle recoil. Toggle recoil is not a technique. Everybody, the drop headpiece, that is not toggle recoil. The toggle recoil is the adjusting machine that we are. The toggle recoil is the toggle created by my shoulders and my arms. When I come together, this is the toggle recoil. The recoil is not me flying off of the segment. The recoil is the innate recoil of the patient's innate after the universal thrust that I put into it. That's toggle recoil. Toggle recoil was used back in the Merrick days. In fact, Cleveland and NYCC taught it for years, called the Columbia technique. Full spine toggle recoil. Not pleasant. I mean, you can imagine, it's not happy. Who has studied Gonstead here? Who has received a knee chest L5 where the person flew off instead of set and held? Not fun, right? Not so much fun. So toggle recoil was way before actually the advent of upper cervical. We have to talk about a little bit about the tables that we use, and then we can see the genesis of that journey. The first table I told you was a bench. Not so happy with the bloody noses, so let's pad the bench. Now we got a padded bench. Yeah, that's not so cool because I'm not so comfortable either. So they decided to split the bench. Cut it in half and split the bench. They would put the hips on one bench, put the chest on the other bench, and then suspend the spine in between, like an accordion, so that the chiropractor can put way more force into it. Let me see if I have a picture of that one. That's a pretty picture. Not so much, but I don't have that one. So HIO was this. Majors and minors did what? What was its purpose? What did it look for? Looked for the major, right? It looked for the one offending vertebra, or vertebra, the one offending vertebral subluxation. The others were either secondary or compensations. Let's adjust that, leave it alone, check it, and see if everything clears out. That was the genesis of HIO. HIO didn't start out upper cervical. It was just, let's find the one, be it L5, T6, or C2. Let's put it in an adjusted thrust, recheck it, and see if it clears out. BJ put that out at Elysium, and then for a number of years collected the data. That data is seen in volume 18. I just told you, $15 on Kindle. It's not mine. I don't make any money from it, but just it's a lot cheaper than in the bookstore. In there has the field data from docs that were out there doing that. And what began to happen is they began seeing that most of the HIOs were in the upper cervical area, either C1 or C2. 50-50 shot. Does anybody dare that to guess or know which one was more predominant back then? C2. So then he began to say, well, if that's the predominant, I mean by huge margins, let's focus on that. 1934, volume 18, the subluxation specific, the adjustment specific is published. 1935, he opens up the BJ Palmer chiropractic clinics. There were a number of them. There was a student clinic. There was the private clinic. The private clinic was the research clinic. That's where he started to do most of his research into the upper cervical specific work. And what I was telling you is once they determined that, what they did was they got rid of the back part of the table, the ones where I put my hips, and I would anchor the body with my knees instead. Because with my knees anchored, I could move my knees either back, I could move my knees either back or forward on the patient, and that would relax different parts of the spine when it was still full spine HIO. When he started to do the work and find out that the upper cervical area was, most of the patient positioning was 90-90. There are variations that take into account variations within each patient. That's neither here nor there for this conversation. This whole conversation led up to who Lyle Sherman was. Lyle Sherman was not the first doc. Who was the first doc that became the assistant director of the B.J. Palmer Research Clinic? Not Dr. Crowder. Dr. Crowder wasn't even graduated yet. This is 1935. So there's a number of misconceptions out there in the world, in the upper cervical world. There's a lot of misinformation out there. Everyone thinks that Lyle Sherman was the clinic director for the 16 years, and that number is even not accurate. 1935, Lyle Sherman was only graduated 1 year. Do you think that B.J. Palmer would entrust his $1 million clinic of $1 million equipment to a guy that just graduated 1 year? Does that, from knowing B.J. Palmer, do you think that's something he would have done? Not so much. The first clinic doctor of the assistant, because B.J. was always the director of the B.J. Palmer Research Clinic. The first assistant was a gentleman by the name of Vic Coxon. Not a really well-known name. He is seen most in volume 20. Have you ever seen the big yellow book? It's a comparative spinographic analysis. It's really awesome. They have one in the library. Go check it out. Go check it out this week. It's super awesome because what they did was This was volume 20, volume 18. So this was published in 1938. Clinic opens in 35. In these 3 years, they took full spine spinographs and cervical spinographs of pre's, immediate posts, and 2-week posts of all of the patients, and then did tracings of them. And you could see the changes that the spine made, and some of the philosophic underpinnings of what was happening is explained in there, and most of that book is written by Vic Coxon. Vic Coxon's from England. He graduated sometime before the clinic opened, went back to England to practice with his dad, and BJ actually called him from England and said, "Dude, I need you here." And he was the clinic director for a number of years, and then he had to leave. He was done. And Galen Price, you know who Galen Price was? Okay, so Galen Price, another amazing doc, but also a 1936 graduate. 36 really got some powerhouses. 36 was like Dave Palmer, BJ's son, Agnes Palmer, daughter-in-law, Leonard Rutherford. Not so much, guys. Do you not have a chiropractic history class? Huh? You have? Not so much.
Go over a lot of modern stuff.
Leonard Rutherford, probably why chiropractic legislation in the United States we're able to practice. Super great chiropractor. I was fortunate enough to know him. A lot of great, needless to say, a lot of great chiropractors from that 30s class, mid-30s class. Galen Price had a couple of distinctions. A, he was the person that BJ trusted with his Department of Philosophy. He was a philosophy chair. 2, he was the first non-Palmer president of Palmer Chiropractic College after Dave died. And I was honored that he spoke at my orientation, my first day, my first exposure to Palmer College of Chiropractic, so that was pretty amazing. And he was an imposing man. He was like 6'7", broad. Even when I knew him when she was older, great pepper had booming voice, very powerful. And then after he was done, and he only covered the interim for about a year, then Lyle Sherman was entrusted as the assistant director. And Lyle Sherman was there until 1951 when he left to go back to Spartanburg. Dr. Crowder, Bud Crowder, was the actual director because he took over just that time that BJ passed on. So Lyle Sherman, how did I even get to Lyle Sherman? What was I talking about? That was a while ago. Doesn't matter. Let's listen to, has anyone ever heard him speak? Would you like to?
Yeah.
Okay. I'm going to play a short clip. I want you just listen to it, and then we'll talk about it. Maybe.
And then blood pressure do return. If that patient can relax a little while and it clears out, it is much better for him than another adjustment. Because innate has to hold the vertebra in place if it is ever going to stay there. And so we tell him that we expect him to hold on to what we have given him. That if he does something to bring that pressure back, each time if he has to be adjusted after that, may make it a little more difficult for it to stay in place.
Okay. Let me just preface that, and I'm going to play it again. I want you to listen to it again. When a patient arrives to the BJ Palmer Research Clinic, they will run through the entire process. The medical doctor saw them, checked them. Chiropractor saw them and checked them. In the chiropractic department, they had spinografts taken, a full set, anywhere between 11 and 21 plates were taken. Neurocalligraphs were taken of the cervical and the full spine. Okay. When pattern was established, pattern indicating that an adjustment was needed, the person did have a vertebral subluxation, the adjustment was made. Immediately post-checked with a neurocallograph and rested. Post-checked again with a neurocallograph to make sure that the neurology had changed, that the correction was made. That same moment, they were sent back to the spinography department and they had the same 11 to 21 plates taken. They stayed for 2 weeks, got checked throughout that time. At the end of 2 weeks, they had a whole nother set taken. So, Dr. Sherman, this, by the way, was his exit speech to the Palmer School of Chiropractic in 1951 when he was leaving. What you missed from the beginning of this was when a patient arrives and we work him up and we give him that adjustment and he's cleared out and he comes in and gets checked again and it shows nerve pressure, listen again to what Dr. Sherman says. I had to listen to this, I don't know, 25, 50 times, and it never made sense to me.
And that blood pressure is due return. If that patient can relax a little while and it clears out, it is much better for him than another adjustment. Because innate has to hold the vertebra in place if it is ever going to stay there. And so we tell him that we expect him to hold on to what we have given him. That if he does something to bring that pressure back, each time that he has to be adjusted after that may make it a little more difficult for it to stay in place.
I don't know about you, but that flawed me. Because I was always taught, if I do my checks, my objective checks, and it says subluxation, adjust. Don't let them live another moment with subluxation, right? That's boom, adjust, adjust. And that's prevailing, right, in most techniques. Adjust, adjust, adjust. You never hear check. Except in the upper cervical work, and then even some of those is just lip service, okay? So what did Dr. Sherman say here? If they come in with pressure, did he say adjust? He said, go rest them. Put them in the rest chair. 20 minutes, a half an hour. Maybe even send them home and have them come back tomorrow. Why? What did he add to that? Innate holds the adjustment. And if I put a thrust in there, regardless of whether it needs it or not, right? He has a vertebral subluxation. If I put another thrust in there, what's the outcome?
It's harder to hold.
Holy crap! Again, it made no sense to me. So where did I go? I have a doubt in my philosophy. Where do I go? I went to Stevenson's, and I was reading. I'm like, dude, this is Lyle Sherman. Was he just like, I don't know, did he drop acid or something when he told that story? What was going on? Was he wanted to jack up BJ because he was leaving? What is going on here? And an epiphany hit me as I was going through the 33 principles. What is the character of innate forces? Constructive, right, in nature. What is the character of universal forces? In fact, what does Stevenson say in his verbiage that he took from, what is it? Unswerving, without solicitude, meaning it don't give a crap for the manner in which it works, right? Does the lightning bolt care for the tree as it splits it in half? No. So here's where the epiphany came from. What's the chiropractic adjusting thrust? How can my adjustment ever be destructive? Isn't it the best thing in the world? How could it ever be destructive? And I started thinking, I'm like, oh man, okay. Here's where humility and ego hits the pavement. Who's a higher quarter student? Higher. Who cares? Vitamin D, right in this moment. How much do I need? Right in this moment. 2, come on. Oh, you must know for you. This is your body. Come on. You don't know. If you don't know how much vitamin D you need in this moment, if you don't know what liver cell number 5,692 needs in this moment, how could you as the chiropractor possibly know how much force to put into that adjusting thrust? Now, for me to accomplish my goal, for me to actually entice innate to make an adjustment, doesn't it have to be just enough? Just enough? So if I make it, I'm at least at just enough. If it's not enough, it's not enough, right? But if I did correct the, quote unquote, the vertebral subluxation, it was just enough, right? Do I know what each person needs? So the likelihood is, if it was just enough, it was probably a little more than just enough, right? Or maybe a lot more than just enough. We've all been on the receiving end, and we've all been on the giving end. Yes? Let's be honest. Yes? Yes. Now, there's three outcomes of that extra stuff. So there's enough for us to entice an aid to make the adjustment. But then there's three outcomes for the extra stuff. One is what? Which would be good? Innate adapt set force for use. Yes? Next one? It's neutral. Nothing. No, okay, we'll call it a wash. Third one? Not so good. Destructive in nature. So every time I give an adjusted thrust, whether they needed it or not, whether they had vertebral subluxation or not, there is a possibility that I am introducing a destructive force. Enough cumulative destructive survival value, and now you have the self-fulfilling prophecy is, Doc, I need to see you every day, or I need to see you every week, or I need to see you all the time for the rest of my life, or I need to see you. Why is this patient not home? They did the best. It was great. They had Parkinson's, and now they don't, but now it's coming back. You're going to have to adjust them all the time. All of these things begin to feed back. So do we not adjust at all and just hope for the best? This is what I want for you guys. Every single one of you. And I don't care what technique you do. I don't even care what system you do. As long as it's chiropractic, I'm okay. I want you to listen to this. It's a minute long. Does that sound good? Not so much? My son Zach, I have 4 kids. My eldest, Zachariah, he's 14 now. He's an awesome kid. I'm not going to post a picture. I don't do it. That's my why. I don't do that stuff. My son Zach wanted to play an instrument, and he picked the viola. I can tell you right now, I'm completely tone deaf. I know nothing about music. I tried when I was a kid. You know, I watched those programs, American Idol and stuff, and there, you know, I listened and I said, it sounded great. And Jackson saying, oh, dude, that's pitchy. Or I'm like, oh, that was horrible. And they're like, oh, it's the best ever. I have no musicality at all. My wife, her mother plays the harp, her brother was a concert cellist, she plays the piano. I thought, okay, cool. So I want to kind of like, you know, engage my son a little bit. So he's practicing in the living room one day, and he's playing his stuff, and he's got the sheet music, and I don't even know what that is. So I said, Zach, what is this stuff? I mean, but I knew they were notes, but I wanted to give him a chance to engage with me on this level. He said, Dad, these little round circles with the stems, those are the notes. That tells me what string to pluck or to pull a bow on. This connector tells me what the flow is and the rhythm. And these are spaces here in between. And I said, oh, okay, that's cool. Let me hear what that sounds like. And he plays it. Good, not great, but he plays it. And I'm just listening. And I was also a little bit disengaged. You know, I don't know, I had my iPad or my phone, Facebooking or something like that. And he stopped. And Zach, why'd you stop? And he looked me in the eyes and he said, Dad, you know, if it wasn't for the space in between the notes, all it would be noise. And I'm like, my son, 14 years old, just gave me a lesson in life that flawed me, like speechless, and you can tell I don't have a problem with speaking. I'm speechless. Does anybody want to care to guess what that instrument is? It's exactly the same instrument. as chiropractors, we're the musician. The notes that we strike, that's the adjusting thrust. It's not the adjusting thrust that does anything. It's not the pluck of the string on the guitar or the viola that makes, or the hammer on the string that makes the music. It's that vibration that occurs after the hammer or the pluck is left. That's us. The music happens in between the notes. The music within the human body of a restored communication of innate intelligence to all cells is where the magic happens and the music happens within the body. But we are so wrapped up, invested in wanting to help them, and the tools that we think we have is the adjustment, when it's the pause, the checking, the analysis to know that they're clear. Just leave them alone. Listen to the music with them. Dance with them. Which do you want to play? Which do you want your patients to manifest? You have this amazing, incredible power to do this. But we have to take pause. Again, I don't care that they do full spine. But even when I talk to my full spine docs, I tell them, how about today you just go in one room and check them, and if you find vertebral subluxation, why don't you just leave them relax, go to your next room and check them, let them relax and go back and see if you find the same stuff. Maybe you do, maybe you don't. If you do, go ahead, do your thing. But if you don't, now you're going to have to adjust. You're going to have to put an adjusted force in there. I'm not saying never adjust, but I'm saying let's listen to the music. Let's use the tools that we have to know that we know when they need to be adjusted and when they don't. Let's make beautiful music with everyone in our community, with everyone around us. Not like, oh man, I have a headache. Crap. Oh man, crap. Just let them go. Does everyone know the story of the seizures? Lyle Sherman and Vijay Palmer? We've already established Lyle Sherman was a pretty competent, kick-ass chiropractor, assistant director of the Vijay Palmer Research Center. In came a patient who had seizures, somewhere in the neighborhood of about 25 seizures a day. Chiropractic at home wasn't helping, medicine wasn't helping, medical industry wasn't helping at all. They came to the Vijay Palmer Research Clinic, worked up like I just told you, found vertebral subluxation. The Lyle Sherman was the one that actually gave the adjustment, cleared them out. Ran a scan the next day and the patient was clear. Did you know what happened to the seizures? It went up. It almost doubled. In the halls, and by the way, does anybody know how tall Vijay Palmer was? This short little dude, he like, boom, right? Lyle wasn't towering, but anybody was almost bigger than Vijay. And he always walked determined, and he walked, and Lyle stopped him. In fact, the Palmer, I have this patient, and he said, well, what's going on? Well, he had 25 seizures, got him adjusted, and they have 50 seizures today. And BJ asked, what do you think he asked? What do you think he asked Dr. Sherman? What did the graph say? It's clear. Okay, leave him alone. Walked off. Checked them the next day. Remember I told you they were there for 2 weeks. Most patients. Checked them the next day, clear. How many seizures? Almost like 90 in this one day. He tracks BJ down again. Dr. Palmer, you know I told you that story about John Doe, yeah. He had 90. Oh, what the graph said is clear. And he walked off. Didn't even say anything. Right? Next day, runs a graph, clear. Any guess on how many seizures? Well over 100 now, in one day. Nervously, again in the hallway, Dr. Sherman says to Dr. Palmer, audio, patient, John Doe. What the graphs say, cut him off with the graph, clear. He said, Dr. Sherman, if you ask me one more time, you're fired, and walked off. Next 2 days, clear, clear, clear. Seizures started to drop, 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 drop. At the end of the 2 weeks, not one seizure. What we do is not the cure-all. What we do is reconnect. But if Dr. Sherman wasn't impressed upon by Dr. Palmer to allow the music to happen, the person probably wouldn't be with us. Well, probably not with us anymore at this age, but wouldn't have lasted, wouldn't have lived. You will be challenged in your office. You will be challenged as a new parent. You will be challenged every day. I had it with my first child, Zach, viola fame. We lived in Costa Rica. My wife and I, we practiced there for 7 years. After the 3rd year there, we had Zach. And we were planning on the whole, natural, again, it's just, step outside of chiropractic. It has nothing to do with chiropractic. I'm just telling you my personal view of life is we were going to have a natural birth. We had this, we lived on a finca, like a little farm. We had tons of fruit trees. We had a grapefruit tree, an orange tree, a guava tree, Hass. I can't see many. Hass. Hash tree. We had 2 plantanos. We had 4 baby banana trees, and then we had a mango tree. We had agua de manzana. You have that? Oh, those are good. You know those Asian pears, but they're like that, but not. Sorry, that's the best I could describe it. But they're red instead of the yellow Asian pears that you take, and it's like literally like pours out water when you take a bite out of it. It's so good. And then we have like 4 different kinds of lemons. You know how here we're used to like limes and lemons? Everywhere else in the world, there's like 12 different kinds of limones. It was the best place to live. We had, everything's made in Costa Rica because of the bugs and the weather, in like concrete and tile. So our bathroom, the master bedroom, was all this white tile. And there was no separation from the shower to the floor, because what do you need one for, right? Here's the coolest thing. A 6 by 6 foot opening in the roof was always open with a grate, like not a small grate, but a big grate so big animals can't get in. So it would rain, I would take showers in the rain. So we had this big, beautiful tub. We were going to have the baby in the tub. Everything was going to be cool, right? You've all heard of that saying, man plans and God laughs? Okay. He decided to laugh on this one. 6 weeks early, she had complete premature rupture of the sac, lost all amniotic fluid, distress. So he said, you got to go to the hospital. So we went to the hospital. This is not even part of the story. I'm only setting you up because of our mentality. We're in a third world country. You have the questions of vaccination. Again, not a chiropractic conversation. This is a personal conversation you need to have to yourself. But there are things that factor in, okay? So he was a preemie, first of all. And in that first year of life, I want to say around month 7 or 8, he got whooping cough. Has anyone ever seen a child or baby with whooping cough? Even if it's not yours, it rips your heart to pieces to see this child gasping, literally gasping for air. Their nail beds blue, their lips blue, their eyes bulging because they can't breathe. My wife's a chiropractor also. So I checked Zach, and actually at the beginning he was carrying nerve pressure, and I gave him an adjustment and we cleared him out. But he couldn't breathe. And it's like, and you're watching this as a parent, and you're saying, at what point, now, I had the best mentors in the world. You've heard of some of them already, I spoke about. The hardest core philosophic upbringing, chiropractic, and we were doing and seeing a lot of people there. Never ever doubted it with any patient I ever had. But here I'm watching my own son. Wait, do you think I had things in the back of my head to rush him to the emergency room when there's an emergency case? So I checked him. I'm checking him and I'd run outside to cry so my wife wouldn't see me crying. Because he's clear. And he can't breathe. And I'll tell you, every time I checked him once an hour. Every time I checked him, and he still wasn't breathing, do you know what I prayed for? I prayed, please show me something so I can hit him again. Right? So I can adjust him again. So I can put that in there, because that's what I do, because that's what he needs. But I didn't, because it was clear. The needle didn't budge. It was right on there. 36 hours. Like literally, almost to the minute. 36 hours. I'm checking him once an hour, never needed an adjustment. He started breathing. And then that afternoon, he was like literally running around. Our principles are our foundation. They are our rock. We're going to be challenged. You're going to be challenged. We're all going to be challenged, whether in our practice or not. The question is, whenever you do something in chiropractic, you want to ask yourself this question, and those who are my students know the question: mediocre or master? If I get a call, hey doc, I'm really tired, do I need to do those drills tonight? My question is, mediocre or master? What do you want? If you have family that you're going to send that live in Detroit, who do you want to take care of them? The person that's partying and didn't take their stuff seriously, or the person that practiced 3 hours a day on a speeder board, that checked 10,000 scans before he even looked and trying to interpret one? That's what you should have. That should be your motto. If I can impress on you one thing, it's just that. Put it on your mirror, mediocre or master. So no matter how tired, how sick, how much pressure you have, take the time to do your stuff. Again, it doesn't matter your technique. But whatever it is, if it's downstage, get that freaking half a tennis ball and thrust into the tennis ball. Run in the nervous scope. If it's toggle recoil, do your thrusts in the air. Because the moment that you make your analysis and put your hands on someone, that person is giving you their life. They entrusted you with their life. Because if we're going to tell stories about this marvelous thing called chiropractic and the power that a chiropractic adjustment can do with all of these named diseases, is the reverse not also the same? That if I manipulate you and cause vertebral subluxation, can I not cause all of those things too? So let's not be practicing on each other. Let's not be hitting each other in bars and at parks and at this. Let's not be saying, hey, I need to do this. Let's take ownership of what we do. Ask ourselves, mediocre or master? Everybody seem like a chiropractic, capital T-I-C, a chiropractor? Well, I was thinking about this, and I'm not claiming any rights to it or anything like that. But when I read chiropractors, you know what I see? Taking our responsibility seriously. It's so serious. My mentor, and I'm going to close with this, and then we can open to discussion. My mentor said this. Everybody heard of "to err is human"? That quote, "to err is human." He said, "To err is human, but as a chiropractor, you don't have that luxury." Mediocre or master? We are blessed to be the musicians. We need to listen to the music. Thank you. I am here if you have any questions, philosophical, if you have technique. Just tell me who you are.
My name is Ulysses. My question is,
So that's a big name.
thank you very much. I'm a second quarter student,
Awesome.
and as you go through the program, you hear about other people in upper quarters, starting to learn, starting to practice. When you say, it's not a just on each, this and that, how do you recommend that one learns a technique?
In general,
Or more specifically, a chiropractic technique if we can't practice on each other?
okay. Yeah, I mean, that's a great question. I can't speak to every technique, so I can only give you my journey. Right away, in my first week of school, I knew I wanted to do upper cervical work. It was an epiphany. I'm not going to tell you that story. That'll be for another time. I come if you like. I mimicked the adjusted thrust on a table that I had in the fraternity house that I lived in. So there was a table there, and I just knew what it looked like, so I would put my hand on, and I would mimic into the table. And I practiced. And then back in those days, there were different kinds of speeders and stuff like that. And I made it my goal to practice between half an hour and an hour 3 times a day while I was a student. That's for the adjusted thrust, right, to build that up. And then I found the mentors that I trusted that actually know how to apply that force to then check me and check my slipping to correct anything that I had created habitually. I can tell you it's much easier to start fresh than it is to correct a bad habit. Priority, I would say, over the adjusted thrust is actually the analysis. So whatever, if you're going in the upper cervical stream, I would say that you need to master the proper protocol of taking a proper scan, heat reading, and doing a proper leg check, right? Each one has its hierarchy of how closely related it is to the vertebral subluxation expression, and so that you could factor those things in. But again, there I recommend finding a mentor to guide you in that. So in our track, in the art of the specific, we have speeders that this gentleman actually makes for us. This is James Choate.
Yeah, Jimmy.
He makes full spine chiropractic equipment, makes upper cervical chiropractic equipment. All of our portable tables, knee chest tables are made by Jim Choate for us, and all of our speeders. We had designed this version of the speeder to allow variations in force so that we can tune our body into applying the different forces. This is, for our students, mandatory tool. So this would be one, if you're looking to do knee posture work or solid headpiece work, even side posture solid headpiece work, which we teach, this would be a mandatory tool. And I wish I had this, because practicing a thrust on a hard table as opposed to this definitely damaged me a little bit. So, does that help?
Yes.
Done.
I've got a more of a technique specific question, is that okay?
No.
On the side posture, solid headpiece, in a lot of the old pictures, you see it's similar, the headpiece is similar to a knee chest posture where you've got some of the cervicals below axis supported by the table, by the headpiece.
So a lot of those pictures that you're talking about, there's only actually like 2 out there.
Right.
And one was like film of BJ just coming off of the thrust, and one setting up. That's important, the angle.
Well,
You didn't finish your question.
No,
Yeah.
so my question is, so if you're gonna set somebody up in a solid headpiece side posture, is the toggle headpiece, the drop headpiece, like on a toggle table, do their lower cervicals need to be back by the headpiece, or can they just be hanging off free off the table if you're adjusting axis?
Yes and no. So it really depends on a number of factors. So There is no cookie cutter. I will get your answer, so let me just fill this in. There's no cookie cutter. There's no 15 degrees of the headpiece for the knee chest table. There's no specific, this needs to be covered. It really all is dependent on the architecture of the patient presenting itself and the misalignment component of the vertebral subluxation and the compensation that's going on in the spine. Does that make sense? There's so many factors that go into it. So this is one of the biggest difficulties in technique. And I think this is probably one of the biggest difficulties and frustrations that the masters had in translating and trying to transmit what they had. Because you know how, like, let's say if we go back in time and we were looking at Palmer specific. The first thing you think of is line analysis, right? Yes? Just say yes.
Yes.
Line analysis on the lateral, on the APO of the mouth, on the median, and the base posterior. Okay? But if you begin to read, but not only what BJ wrote, but Percy Ramirez, who was his spinography guy, when you look at the pictures, what was BJ doing with those x-rays? You ever see him with a magnifying glass? Did you ever see lines on those x-rays? He said he looked at a pair of spinographs for 2 hours. 2 hours. The guy's not making that crap up. I know, because the doctors that I got trained by were trained by him and saw him. He would look at them, and he would see the movement. He would see how that offensive vertebra got to its insulted position and what he needed to do to unlock that. But he looked at everything. He wasn't looking just like look at the atlas. He saw everything, and you go, well, how do you know that? Because if you look at and read everything that he wrote, he talked about everything. He talked about atlas high, wedge low. All of these things came into account, but I don't think they were readily explicable in an easy fashion. I think that's where a lot of other techniques stems from, because of the difficulty of explaining something that a master does automatically. Does that kind of make sense? Oh, we're there now? Sort of? So I think a lot of the techniques came in trying to simplify what was taken for granted by these giants. So where you place the patient on the headpiece, whether it be knee posture or side posture, if we're talking in the upper cervical world, is completely contingent upon that case. Completely contingent upon the architecture that they start with. What are their condyles doing? Is one steep and one shallow? Are they both steep? Are they both shallow? Is one higher than the other? Is one twisted? Are they here in a more normal fashion? Are they out of place? Is the lower cervical a convexity on this side or a convexity on this side? Beginning to understand? All of those are going to factor into how we set them up, set the headpiece, set the stabilization, where we contact, and all of that.
I guess my question is specifically to when you have a drop headpiece, you're shearing the joint between the atlas and the occiput or the axis. And
That is the theory.
And so if you're not having a drop headpiece and you're in side posture, like in the knee posture, knee chest posture, are you now no longer shearing the joint? You want whatever segment you're adjusting to be backed up by the table?
No, you're always shearing the joint. No matter what. You're always, even on a gun slip, you're stabilizing, you're still shearing the joint because you're getting cleavage. You just don't have the mechanical advantage of the drop mechanism that's dropping this bowling ball and the weight of the neck. So it's just a different application of the force, but they're still both shear forces. The answer to your question is, in most of the cases, that the neck is stabilized on the headpiece, in solid headpiece work. Generally speaking. Okay?
Thank you.
You're welcome. What's your name? Paul.
First one
Where you? Yeah. Where you at in your journey here?
I'm in my 10th grade graduating this week.
Congratulations. Yeah.
First thing I want to say is thank you for your presentation today, because it brought me back to the essence of why I fell in love with upper cervical. sometimes I feel like here it gets watered down and it's just not, you breaking down the history of things and it really motivates me to get back into the green books again because, you know, to know where you're going, you gotta revisit the past, absolutely. Question, I have something about clarification of what you said about destructive forces.
Yeah.
So if the scan is not clear, and you adjust the person, and the scan is still not clear, was that a destructive force that you put into the body?
So that again falls into the outside stuff. So that falls into one of three possibilities. Still, so if I come here, right? That sounds awful. If I do this, the likelihood is I'm not going to cause a vertebral subluxation, right? But a force is still introduced into her body. So there's three outcomes to that force. One is that the innate intelligence of her body was able to take that force and adapt it for use. Right? That's a possibility. Second is it's a wash. The third is that there's some damage. Maybe it did some damage to the skin, maybe it did some damage deeper, depending on how hard it hit, depending on what areas are affected. Same goes for that. When we talk about the adjusted thrust, if we have a graph that we took, we know that's their pattern, and we're taking a lot of things for granted, right? If we know that's their pattern, and we put an adjusted force, regardless of whether we hear cleavage or pop or anything, if the scan is still identical, nothing has been changed as far as the vertebral subluxation goes. Still, the force, or a part of the force that you introduced, could have been adapted for use in the body, just not use enough to correct the vertebral subluxation. Or it could be a wash, or you could have been damaged. Or a combination of the three. Does that answer your question?
So the crafting behind is that you want to be able to clear the skin so you know you put in force that.
Right.
That's the mastery behind it.
Right, and when you bring up a beautiful point, no insult to any technique or whatever, the comment that the next pre is the best post is the most ridiculous comment in the world, and never do that. Because, do you understand that have you heard that before?
I haven't.
Okay. So you're taking scans, right? You have a pre-scan, you make an adjustment, and then normally you would take a post-scan, either immediately or sometime within the time period of their visit. In my office, the average is 20 minutes, 20-minute rest period, right? Okay? Some are longer, some shorter, 20 minutes. I post-check them. That's my post-check. There are some people out there that say that, no, don't worry about that one. The best post is the next three. So when they come in 2 days or they come in a week. My question to that is, let's say they cleared. Let's say they cleared. How do you know it was from the adjustment you gave that day or the lovemaking that he did with his wife yesterday or the falling off the swing that he was playing with his kids on this morning? Do you get that? Equally, they come in and it's pattern. You still don't know. Maybe you did clear him out. And you don't know what transpired. The same three scenarios I just gave you could have subluxated him again. But if you're doing that as your criteria, you might be not adjusting when they need to be adjusted, or adjusting when they don't need to be adjusted. You should have an immediate neurologic change if you correct the vertebral subluxation. You should have an immediate, if you understand the neurology, that stuff like cicatrix and scar tissue and not correct. Okay? If you make a chiropractic adjustment, the neurology has to manifest it. You will see that in your graphic. I'm glad you brought that up. That's a super important point. Russ.
Hi, my name is Tim. My first quarter.
First quarter. That's so awesome that you're here.
Yeah, so I'm in my philosophy class, and in my first week, my professor told us a story of how his wife and also his kids had whooping cough, and they were suffering for almost 3 months, and he just told us the story, and at the end they all got better from it. And I remember going home that day thinking, what would I do, and what would I think if I were in that father's position? And I think I kind of would have put myself in the same train of thought as how you would. Maybe you would check for self-fixation, but at the same time, do I have to take my child to the emergency care? So my question is, if a person is subluxation free, is there a disease the person cannot adapt or recover from? And if there is, then how do you know how much that person can adapt and make the decision as a chiropractor to take emergency care?
What's a better question than that? What's a better question than that as a chiropractor?
When do you refer out?
What's a better question than that? Here's the question. Here's a better question. What are you telling the patient, a new patient? What is the goal of chiropractic? The goal is ultimately to get it to a state of restoration. Yes? What can it do in a state of restoration? Okay. So does that mean we live forever if we're under chiropractic care? No. So there are limitations of the matter. Very good likelihood that Mr. Tabak here can deadlift a little bit more than me. Just a little bit, I think. Why is that? Why is that? I'm a buff guy. Because of the limitations of my matter. There's only a certain amount. Now, as the chiropractor, if we know what our goal is, we know what our job is, shouldn't we transmit that to the patient as well? So is your job to cure the disease? No. Do they not come to you for a reason? Your job is to make them understand what your role is in their journey in life. And it's a chiropractic journey, not a medical journey. So the answer to your question is, I don't know of anything that the human body can't restore from. Doesn't necessarily mean they will. Does that make sense?
It makes sense. So everybody has different level of how much they can adapt with the limited matter that they're given.
What's your name?
Justine.
Justine. So I came over here and did this to Justine, right? Maybe I did it a little harder. I can do that. Else I'll find me. So if I do that to him, the likelihood is I don't cause a vertebral subluxation or probably any damage at all. If I did that to his newborn baby in a day or two, do you think it would have the same?
That was my buddy Harrison.
Oh, that was Harrison.
I thought you were trying to think like it.
He is not having a baby. Whatever I said, wipe that out. That he knows of, at least.
He didn't know that.
Does anybody have a baby? My baby. That baby? How old?
16 months.
Oh, name?
Savannah.
Savannah. Oh, that's pretty good. If I did that force to forget about you. If I did that force to Savannah, do you think that it would be equally not as impactful? Or would it be more significant to Savannah, a newborn? The limitation of matter is dependent on so many factors. One is how much matter is there, the state or condition of the matter. Because if I have a vertebral subluxation that is existent in my body for years and years and years, it begins a cycle that affects the vertebra. You don't know what the vertebra is. The vertebra, which then affects every other part, which is the myomere and the neuromere and all of those other meres. The neuromere supplies everything from that vertebra, and if that has a vertebral subluxation, that means that it is out of the loop of innate intelligence control specifically. Does anybody have a volume 14 with them? I do. Okay. Oh, look at that. Boom. Choke table. Okay. How crazy is that? Dude, you better get a steep discount for that. Okay, look at this. Huh? Did we? I'm leaving soon. Yes, thank you. Okay, what's that called? Normal complete cycle. This is one single iota in time of the perfect communication between brain cell and tissue cell. Billions and billions and billions of this are occurring all at the same time. When a vertebral subluxation occurs, something else happens. And that something else is this crazy, huh? A6. This crazy abnormal complete cycle and vertebrate cycle. So what happens is we introduce a force that overwhelms. Yeah, I could be here only. This is something to be passionate about. And something that you guys need to own. There's so much misconception out there in chiropractic. Your body, your innate does not cause a vertebral subluxation. It will never cause a vertebral subluxation. Vertebral subluxation is bad, and it occurs because of the inability of innate intelligence to adapt the force due to the limitation of matter. Think of the baby issue. Slap Jason, boom, he can handle it. Slap the baby, they can't. Limitation of matter. It's not that it's not a circuit breaker. It's not to save something worse. It's not a good thing. It's not a potential.
I just add, so you can say the limitation of matter is relative to the resistive force.
Yeah, well, no. No, because the resistive force is also innate is 100% and it's perfect, right? But it can only work in the matter in which it resides. So if the matter is weak, no matter, it doesn't matter. It's the matter that causes the gap. Inability, right? And that causes the vertebral subluxation. So once you have in this cycle, once you have that normal complete cycle that was communicating well, in comes that universal force, and then what happens is we go off tangent. It's now not going through its normal process. It still has a cycle called the abnormal complete cycle in the vertebra. So all of the tissue that controls the placement of the vertebra now is whacked out. The neurometer is whacked out. It either has plus or minus function on a very simple level. So either, if it's the myometer, either the muscle is pulling too much or they're not pulling enough. If it's supplying the kidney, there's supplying too much or too much function or minus function. What's that? Okay. Wait.
One last question?
Yeah, no, wait, I'm not done. What was the question? The original question that started that? Were we still on your question?
So my question was, is there a disease subluxation-free person cannot adapt to? And if there is, then when do you draw the line to say?
No. The answer is no, and that wasn't, I don't know why I went off on that tangent.
But I mean, you answered my question already.
Yeah. The idea is that's not your job. Your job is just to check for, know that you know that you can correct it, and then leave it alone, allow the body to do. If they want to go for other stuff, they can go for other stuff. You can instruct them on that. Obviously, if they pass out on your floor and like cerebral spinal fluid is pouring out of their nose, I would probably not run a scan on them. I might call 911.
Quick question?
The question is, isn't the mental impulse which arises in the brain to the body, to tissue cell, isn't it intimately dependent upon afferent signals the brain knows how to interpret it and therefore what to do? Is it bi-directional like communication pathway?
Yeah.
So I think like, not to downgrade it, but like I'm always interested in, like we need cells telling the brain where they are in space and what to do so that we know how to operate and to signal what's going on. It's kind of like it's a relationship there, right? So I guess partly for me is, it's important, it seems, to keep that circle open so things communicate, especially from the brainstem. Don't we also need clear signals coming from the brains down below?
Absolutely. And that actually brings up another point, actually a tangential point on that too. But we don't, that destructive stuff, right, universal force, we cease to exist without it. You get that? Because innate forces are only made from adapted universal forces. So we actually have to have those. We have to have that interplay. Hopefully it's a perfect interplay, right? Yes. And in fact, in the art specific, our model is the mechanical receptive disaggregation model. So we work on that model. But the question is, it's almost like a chicken or egg kind of question, where does it start? But if you look at the normal complete cycle, and if we're talking about manifestation, we have to look at the universal force and the universal intelligence and where that stems and comes into the cycle. And it makes no sense that it comes into the cycle at the tissue cell. And we can go into a whole other argument about that. And the only example to use, and that would be the tissue cell in and of itself cannot function on its own without the control from above. So, one more and then.
All right, my name is Steven.
Harrison, from this point forward. Sorry.
So the neurokilometers NSAM was kind of the first of its kind, right, to objectify the analysis of the nervous system.
Yeah.
And it was kind of like the first shot and it worked, right? Like, holy cow. And then we've developed on that and we've made it more precise.
Still a great instrument.
So, well, I'm only asking, so I've noticed a couple times as you've gone through, you've done a really good job of saying whatever technique you choose to do or whatever set of things that you choose to do in your office, just call it what it is kind of thing. But you make a really good point of saying if they cleared the scan, then they're good. If you made the scan, they're not.
Yeah.
Are there not any other ways to assess the nervous system or other ways out there of, who knows, from brain scanning to, because on the scanning, you don't just scan at the location, you get distal to that as well, so is there not other things we can mention?
So the answer to that question is yes. But we have to look at, again, the whole tangent that I brought up before was, what objective test of a component of a vertebral subluxation is closest to the vertebral subluxation? And I'm not talking about proximity, just because the scan is close to that. I'm talking about what it's measuring. Are we measuring something closest to the neuronal function, so to speak? The gold standard across all health measurements is heat. And you can go into looking at the reasons why. That's for another topic of conversation. For all of chiropractic's history, and including today, that's still top on the list. As you do others, it begins to go down in validity and objectivity. Okay? Heart rate variability, can you use that? Of course you can use that. It's amazing. Because here's what you want to do. Here's where philosophy meets art. Here's where philosophy meets science. What are we trying to measure? Nerve interference. What are we trying to discover? The subluxation. And what are the components of a vertebral subluxation in the classic model? MOPI. Everybody heard of MOPI? Misalignment, occlusion, pressure, and interference, right? That's MOPI. The MOPI part, you can see on spinographs. Right? The pressure and the interference, if you have no way of monitoring that, as far as I'm concerned, you're not analyzing for vertebral subluxation. And if you're addressing that, this is why diversified is not a technique. Right? So you need something that can measure. Now, mental impulse, this gentleman who just left said, it's intangible. We really don't know what it is yet. So how do you measure it? Well, how do you measure anything? I mean, electricity. Do we know where an electron is? I mean, really? No, somewhere in this freaking cloud. But we know it's there. Do we say it's not there because we can't empirically see it, taste it, or smell it yet? No. Same thing with the mental impulse. But I can see the manifestations of an electron on my studies, right? I can see the manifestations. It's the same thing with the mental impulse. If the job, what is the job of innate intelligence? Ultimately to adapt, coordination and adaptation. What does a measurement of heat do? What does pattern analysis do? Checks for adaptation. What does heart rate variability do? Checks for adaptation. Now I have tools that I can use to link me through our chiropractic philosophy back to the actual mental impulse and innate intelligence. How cool is that?
Well, I see what you mean, how you don't want to get too far away if you don't want it to be a third or fourth
generation
effect of it. But so obviously the heat would be, and what you would think would be the closest representation of that.
That's
But I mean as far as checking the actual, because they have scans you can do from checking electrical activity, which would be direct influence of activity.
So electrical activity is now, you're talking about like
fire,
potential and all that kind of stuff. That's neuronal.
Okay.
That's neuronal. The mental impulse is outside of that, on top of, a carrier of. The mental impulse is not equivalent to the nerve impulse.
Well, I was just saying, because the heat is the nerve. So I was just saying there.
No,
I feel like
the heat is not the nerve.
But I'm just bringing it up. I've had questions.
No, this is great. This is great. Everybody has the same question. The heat, the pattern we get from the heat is the result that we're looking for. It is a manifestation of adaptation. Example, if I take a scan, and my scan looks like an S today, and I take it tonight, and it's an S, and I take it tomorrow, and it's an S, and I take it in a week, and it's an S, and I take it in a month, and it's an S, is it fair to say that that's static? What is the job of innate intelligence? Adaptation. Adaptation, another word for that is? Change. So if I have that, the same, all the way through, my body's not changing, it's not adapting. You see how we can connect that directly through that PI part of MOPI, the vertebral subluxation? Those are the tools we have. If I take, let's just say, needle EMG, all I'm testing is the neuronal function of it. That's completely...
I was thinking more like functional MRI, frequency of firing, not necessarily muscle tendency or anything.
It's still the same thing, because frequency of firing, we're still talking about the matter. Right?
No, that helped.
Because the mental impulse is outside that. 1 foot in and 1 foot out. Cool, huh?
Yeah, I appreciate that.
You're welcome.
At what point in your career did you feel like you were
now at the level to pass on what you have to other people and actually teach?
I still don't even feel like I am. You know, I've had such a great experience from my mentors, true giants. Honored to have been given that. They're gone. And I felt that even though I don't know necessarily if I felt worthy to be able to, I felt that it was my responsibility to carry on a legacy so that it doesn't get lost, that it doesn't get changed, and it doesn't get sullied. That's my reason to be.
When you're talking about when brain cross communicate with tissues below, how do you, and that a cell cannot operate without the innervation, how does that account for things such as the beating of the heart after or
Perfect. So I take that heart out, and I run with the heart. Does it beat heavier, faster? I lay down and I sleep with that heart. Does it beat slower? No. It's just its design that it has its own pacemaker in there, but it's not a neuronal control for adaptation. Only when it's under the control of the brain does it now adapt to the changes and challenges put on the body. Last question.
I had a question when I was reading, and I don't know if I was just misunderstanding something, but I was talking about like the subluxation not being permanent.
Always there.
Yeah.
That's a really tough passage.
But then it said something about like it being like locked and permanent in
three-dimensional.
and so I didn't understand the
Yeah, you're gonna have to save that one because that's a common question. Quick question. We're gonna have you more all day.
I know, but so what is there, what do you say if someone says, well, you know, you can break apart the skin and some of it looks like the pattern, but some of it's not, or it looks like the pattern, but it is literally translated to the other side of the page. I mean, how do you know if you're saying, so if the change is a change or no?
Yes, no.
All right, so I'll see you tomorrow.
Yeah. That's such a, I mean, for everyone in that and listening to that, it's such a deep question. There's so much that you could read into the key patterns. I mean, literally, you could read women's menstrual cycles, you could read changes in hormones, you could read changes in activity and behavior and things like that. There's so much in it. We'll go over that.
Thank you, Dr. Reddy.